Hi, welcome to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor at JAMA Network Open.
And I'm Angel Desai. I'm the JAMA Fishbein Fellow.
If you're following along live, please send us comments or questions through the Twitter account at our Twitter handle, JAMA Network Open, or comments on the Facebook or YouTube videos. So there was a new USPSTF, the United States Preventative Services Task Force, which is one of my favorite acronyms to say, recommendation on asymptomatic bacteria that came out last week in JAMA. And we today are going to talk about an editorial in JAMA Network Open, the 2019 USPSTF report on screening for asymptomatic bacteria, lessons from history. And we've got first author, Dr. Kalpana Gupta. So Dr. Gupta, welcome.
Thank you. It's a pleasure to be here.
So just tell us a little bit about yourself and what you think about the recommendation.
Sure. So I'm an infectious diseases physician, and I've been working on UTI for over 2 decades. UTI and ASB are finally hot topics. It's very exciting to be part of this. So I've been working actually on the IDSA asymptomatic bacterial guidelines that just came out earlier this spring. And I was asked to write an editorial on this task force recommendation. And it really was a great opportunity to look at the 2 different approaches to making recommendations for this very common practice. So I can tell you a little bit more about that.
Yeah, go ahead.
So essentially, they looked at 2 different populations. One was pregnant women, and the other was older, non-pregnant adults. And what they came out with was a recommendation that was a B rating for pregnant women to screen and treat asymptomatic bacteria. This was a little bit of a change from what they had recommended previously. About a decade ago, the recommendation was an A rating for that. And some of the rationale for that is, in fact, we're learning more and more about the harms of antibiotics. And whenever we make recommendations, we're really doing a risk versus benefit analysis. And when there's data suggesting that there is some benefit, we still have to weigh the potential harms. And I think more and more we're recognizing that using antibiotics, especially in asymptomatic patients, is associated with harms that we cannot ignore, including obviously the adverse events related to the antibiotics, but also the downstream events, changes in the microbiome of the gut, increases in C. diff infection, increases in resistance, and that was weighed against the evidence suggesting that there might be a benefit. Of course, there's new data out in pregnant women from the Netherlands suggesting that the benefit may not be as great as some of the previous studies had suggested. So that was one population that they looked at. The second population, in terms of adults who were not pregnant, again, the recommendation was a grade D here. So do not screen and do not treat. And that's very similar to the recommendation that they had back in 2008. There was actually not very much new evidence to look at. But again, that risk versus benefit analysis weighed in the favor of recommending against this practice.
Okay. I think that this is a really, really important topic, and particularly obviously coming from an ID background, but just in general, on the inpatient setting and in the outpatient setting, this comes up all of the time. And I actually wanted to ask you about something that you had mentioned in the editorial. You talked a little bit about the new recommendations, but then also kind of took a broader look and identified a couple of populations I really appreciated, and sort of the fact that there's limited evidence for these populations, which actually may benefit even more from having a closer look, such as people that have indwelling urinary catheters, people that are in long-term facilities, et cetera. I was hoping you could just expand upon that a little bit.
Sure. And in the IDSA guidelines, we actually much expanded the populations that we looked at in this iteration compared to the 2005 iteration, and it covered many of those populations that you just mentioned. Part of the problem, again, is the paucity of really robust data. But as a guideline committee, we were able to take the approach that, again, this is a risk versus benefit analysis. So even if there's a paucity of data suggesting no benefit, but there's some data suggesting no benefit, there's certainly a lot of data suggesting that there's harm. And again, so if you take that approach over and over again, then you can essentially stand behind a recommendation that says do not screen and do not treat. And so we were able to expand in the IDSA guidelines the populations for which we made that recommendation, including patients who had renal transplants, which always was one of the populations that we used to think about, like, oh, they have a renal transplant, maybe I should screen and treat this patient. We were able to look at actually patients who were coming in with delirium. So that was one of my favorites in the guideline because I worked on that part. I think that's one of the most common reasons that people feel like, oh, the patient's not really asymptomatic. I should screen the urine and I should treat them because the delirium may be related to an infection. And what we were able to do is actually pull out, believe it or not, there's a randomized trial evaluating fluoroquinolone versus doing nothing for patients who have mental status changes. It's very small. It was published a long time ago, but there was no benefit to treating. And we were retrospective cohort studies that also back that up. And we were able to make a recommendation in that patient population. So again, we were able to expand the populations and most importantly, as you already mentioned, these are populations that may be more likely to have asymptomatic bacteria and certainly may be more likely also to have harms from antibiotic use. They might be having antibiotics for other reasons. They may be in and out of the healthcare system. So it all makes sense to try and, again, take a risk versus benefit approach and make recommendations where clinicians are making those choices every day anyway.
Yep. We've got a bunch of viewers who've joined us. I want to welcome Matt Sparks, Bebo, Kanan, and Carol. And I'm sorry, I'm probably butchering all of those because they're not phonetic names, except for Matt Sparks, of course. So welcome. We're talking about the USPSTF guidelines on asymptomatic bacteria. And what you're just talking about, delirium, is really what resonated with me and what I think about the most. I'm an ER doc, so I'm not doing a lot of just screening for asymptomatic bacteria other than in pregnant patients. So good to know that we're doing okay there. And with delirium, it's really tough. Again, the USPSTF recommendation does exclude hospitalized patients, so it's a little bit different.
Right.
But oftentimes, obviously overtreatment with antibiotics is bad, especially in patients at risk for multi-drug resistant organisms, et cetera. But sepsis is also really bad.
Right.
And we're also dealing with urinalyses and not cultures most of the time.
Yes.
And one of the things that the longer I've been practicing, the more I realize that we talk about interpreting UAs like it's really easy, and it's actually really difficult to do. And it's very difficult. It's kind of like tympanoscopy. Like looking in a kid's ear and figuring out if there's an ear infection is a lot harder than we all talk about.
Well, and I think that's a really important point. And actually, we just published a paper evaluating pyuria. So there's been many, many papers looking at asymptomatic bacteriuria, but not many people have looked at pyuria. And in fact, as you point out, that is usually the trigger point for people, right? They check the UA and the UA comes back and you often not even waiting for the culture. This was a preoperative population. We were able to show that pyuria, even in the setting of a negative urine culture, was often a trigger for antibiotic use. And most importantly, though, that treated versus untreated pyuria was not associated with any improvement post-op in these patients. So that was a surgical cohort. But again, we relied on that risk versus benefit analysis. And in fact, C. diff was increased in patients who were treated for their pyuria. So I think that we need to get the message out that the UA, as you point out, is not easy to interpret. I think that what we're seeing is it may also not have that much significance in terms of the patient you're looking at. Now, to your point about sepsis and delirium, I think it's very important because it's scary, right? When you have someone who has mental status changes, you don't want to miss infection because obviously giving antibiotics in that setting could improve outcomes. So what we state in the guideline is if it's just a positive UA or culture in the absence of changes in vital signs, high white count, something else to make you think that they have systemic infection, then do your due diligence. Don't ignore the patient, but do your vital signs, follow them, try to figure out if there's some other reason that they're having mental status changes. Remember that the definition of delirium is that it waxes and wanes. So remember that it might get better or might on its own. And even do things like hydration. So it's okay to wait if you don't have obvious signs of infection alongside that positive UA. I think the urine is a very easy test to get. That's part of the problem. When you look at, even compared to doing blood, urine's almost easier to get. So we end up relying on it. It depends on the patient.
Right. I know. A lot of ER docs will joke about how we spend a lot of our shift waiting for urine. It's a lot of blood. But yeah, and I think you hit it too. Another thing that's really I think helpful is or one thing that always sticks with me is that just because there are signs of infection on the urine doesn't mean that that's what's causing the sepsis in patients who are floridly septic, and that basically there's an issue with the search satisfaction. So one of the things that always fascinates me is when we're getting this wrong on both sides of the equation, where we're treating too much asymptomatic bacteria and then being happy that a little bit of pyuria is causing the severe infection.
Yeah. One point that I kind of wanted to make, just thinking about, because I think you even mentioned in the editorial this sort of over-reliance on the UA or the urinalysis. I think I kind of wanted to ask you, sort of thinking about it from a systems level, and thinking about this as sort of a process. I think more and more hospitals are sort of having to deal with the fact that things like catheter-associated UTIs are being tied to reimbursement. And so having something like a reflex urinalysis, for example, is sort of an easy way to be able to try to reduce that. And I just wonder if you have any thoughts about what other strategies hospitals or systems can use to try to tackle this issue.
Well, it's a really good point. And I have to say that I have mixed feelings about the reflex UA to culture, although it's become very popular, and certainly in some studies and in some hospitals and from colleagues I've heard, it does reduce the number of urine cultures that are being performed in the lab. It does probably reduce the amount of antibiotics that are being used in patients who are asymptomatic, certainly those who have negative UAs. The problem is it does push us towards the UA, again, in terms of relying on it. And my teaching is go back to your patient. Does the patient even need a UA or culture? Now, sometimes we get that urine for other reasons, obviously. And there it's quite helpful to say if they don't have pyuria, don't do a culture. Certainly the negative predictive value of absence of pyuria is very, very good. We know that. And I think that's a very reasonable approach. But even in those who have pyuria and go on to get a urine culture, go back to your patient and figure out if they actually have symptoms of infection, whether it's actually UTI versus something else. And then always be willing to sort of change your diagnosis once you get more information. And I think that's another piece that we need to teach, certainly house staff, is to don't anchor on one diagnosis, because you often have that positive urine and it may or may not be related to what's going on.
Right. Yeah. Well, it's been really great talking with you. This is fascinating. Unfortunately, this is a topic that keeps coming up and hasn't gone away. So I'm still an optimist. There's lots of room for improvement here. But thank you so much for the editorial, and thanks for joining us.
Thank you. Bye-bye.
We've got a couple more viewers who've joined us, so welcome Pierre, Angelo, Muzella Beg, and Judith Strimish. And again, apologies for my pronunciations.
Hey, everyone.
Yeah, and just especially a few weeks ago, we celebrated the 40th anniversary of the release of the House of God, which makes, I forget which rule number it is, but the law of you can't find a fever if you don't check a temperature.
Yeah, so, that's right.
Always an important guideline. So now we're going to move on to our table of contents. So Angel, start us off.
All right, so first off, we're going to talk about association of BCG vaccination in childhood with subsequent cancer diagnoses, a 60-year follow-up of a clinical trial. So this was a secondary analysis of a trial that had looked at BCG vaccines. It was pretty cool. They actually had looked at 2,000 school children of American Indian and Alaska Native descent, and had sort of done a review from 1935 to 1998, looking at individuals who got BCG vaccine and kind of what the events of those were later on. And so in this study, they did a retrospective review, and they specifically wanted to look at the association of BCG vaccination with cancer rates. And what they found was that of all of the participants, there were a total of 325 malignant neoplasms that ended up occurring, but that the rate of cancer diagnosis between those that had BCG vaccine and those that had received a placebo really weren't statistically significant. And this included subgroups of those that had leukemia and lymphoma, and this was important because in prior studies there had been potentially, there was a little bit of a controversy, but there had been potentially an association there, so that wasn't found. Conversely, they did find that the rate of lung cancer was actually significantly lower in the children that had received BCG versus placebo. And so I think that was something that was sort of unique. There were some limitations to this analysis. It is a retrospective review. It's a post hoc analysis, so they couldn't control for all of the confounders that could be associated with lung cancer, but still something of interest, I think.
Yeah, and also they were looking at a lot of subgroups. So the fact that you're comparing this pretty big population of 3,000 kids over 60 years, the chance of something popping up just by random chance of a difference, but there is a little bit of separation in that lung cancer-free survival graph, which is impressive. I was also impressed. There were a couple of things that impressed me. One, they were only missing, I think, 200 patients total after 60 years of follow-up. We can't get that kind of low rate of of missing data in like a 6-year study.
It's true.
And also, I was at first when I saw that they started the actual intervention was 1935 to 1938, and the initial study wasn't published until 1952 in JAMA.
Yeah.
And at first I was like, wow, I wonder what a lot of that delay was. And part of it is they were looking at relatively long-term outcomes on the order of like 10 years. And also there was a major world war in the interim. And they actually talked about just the way they kind of like talked about it just casually, like, oh, well, we our clinic follow-ups went down as we lost some staff because they had to go overseas in the military from 1941 to 44.
Yeah.
And it's always interesting to me to read reports of data from that are that old.
Yeah, no, it's great.
Yeah. All right, so moving on. Welcome, Laura. We're doing our e-table of contents. Next up, we've got the association of early high plasma to red blood cell transfusion ratios with mortality in adults with severe bleeding after trauma. So figuring out what the correct mixture of blood components to give to sick trauma patients has been very difficult to figure out. A lot of studies are plagued with survivorship bias because things like FFP, because it's frozen, has to thaw, it takes 45 minutes or so to get ready. That's after the decision to transfuse. So there's a lot of survivorship bias where a lot of the initial studies, the patients who got FFP did better because there was patients who survived long enough to get FFP. So there have been a couple of studies trying to tease this out and figure out the optimal ratio. In this study, they looked at 12,000 patients in a French trauma registry. There were 900 who got big doses of blood. So basically, I think it was 4 units or more. They defined severe bleeding as people got 4 units or more of packed cells in the first 6 hours or died before receiving those first 4 units. It was a sick group. Not surprisingly, about a third of them died, 34% mortality at 30 days. About 500 patients had the high ratio and 400 patients had the low ratio, which they defined as a 1 to 1.5 ratio of FFP to packed red blood cells. So basically 4 units of FFP to 6 units of packed cells, which is about what we do in practice, and basically found the hazard ratio, their point estimate was 0.74, which just barely met statistical significance with the upper end of the confidence interval at 0.97. And you can see the graph in their survival curve. There's pretty decent separation there, and it looks like there probably is a real difference here. These methods are a little bit above my pay grade here, but they do say the way they did the Cox proportional hazard should account for that survivorship bias, which is nice. And gives us some more information in an area that we have limited data, and it's hard to randomize really sick patients to treatment or not treatment, and we have to do a lot of hand waving physiology about this stuff.
Well, I wanted to ask you too, from a practical standpoint, as somebody that works in the ED, how do you implement something like this in terms of getting those ratios right? And I know you mentioned it's like 4 to 6, I think you had said.
Yep.
So, but it seems like in a situation like this, in a really urgent situation, getting that may be difficult.
Yeah. So most hospitals, big trauma centers that deal with it, generally do just have a massive transfusion protocol where I don't have to think about what I'm giving the patient. And generally, if we decide the patient's sick enough, kind of just pull that lever and they get all of the blood.
Okay.
And generally, it's if you think they're going to get, usually I think it's 4 or 6 units within 24 hours or so. That's usually around where the threshold is, but basically just a clinician who deals with trauma thinking, they're sick and they need massive transfusion. It just generally triggers it, and the blood bank just starts thawing plasma, just starts kind of giving it in kind of a routine formula.
So those ratios could potentially be built into something like the EHR. Okay.
Yep, exactly, yeah. I mean, a lot of times we're not even seeing the EHR. We just order massive transfusion, and the blood bank figures out the details, which is really nice.
That's nice, yeah.
Because especially in these big sick trauma cases, there's a lot of things going on, a lot of stress.
Right.
So the fewer things I need to think about, the better it is for everybody. Which is very nice. All right, so next up, this is an interesting research letter on voluntary versus electrically stimulated activation and age-related muscle weakness. We've got a couple of new viewers, Ahmet and Ayed Wahabi. Welcome.
Hi.
Thanks for joining us. So this is an interesting research letter. They looked at 67 older adults who don't have any neurologic disease, they're community dwelling, not nursing home, et cetera. And they had them do these maximal isokinetic leg strength tests, which means they're doing the same speed of movement strength as they're pushing on a machine that's calibrated for whatever it does. And they wanted to measure the degree of voluntary inactivation. So basically, when the patient, when the participants had, their muscles kind of working all the way, they then stimulated them electrically to see if they could kind of get even more effort out of that. Basically, is there more muscle that's not being triggered by the nerves? And they found there was some. And basically, during this maximal voluntary effort, the stimulus could make even more force come out. So basically what that means is that there's more muscle that's not being used. And what their hypothesis is basically that this is evidence that, we know weakness in as we age is bad for a lot of reasons, but that some of this may not be that the muscles are weaker, but that either our brains or our peripheral nerves, for whatever reason, or I guess the spinal cord, aren't triggering the muscles.
Right.
So it's, hypothesis generating more than anything else, but also, potentially leads to some different areas to look at therapies or places to improve, sarcopenia and muscle strength in older people.
And did they have, the one thing I wasn't sure about, did they have people categorize their weakness, sort of their perception of their weakness up front? Or was it kind of...
I think they measured what they could do on the machine.
Okay.
I don't know if they actually did categorize. And it's also a research letter, so there's only a few hundred words.
I did look up what this timer looked like. Yeah. It was pretty cool, actually. Nice. Yeah.
I'll have to take a look at it. So some of these things are fun, especially stuff that's out of our own specialties.
Yeah, exactly.
It's interesting to see this kind of stuff. And some of this kind of, function lab stuff can be pretty cool.
Yeah, definitely.
Yeah. All right. Next up, association of comprehensive smoking cessation program with smoking abstinence among patients with cancer. So there's some other studies that show that patients who have cancer, especially lung cancer, do better when they stop smoking, which, it's easy to, I think, be cynical and say, I've already got cancer, what's the point of quitting? And what they did in this study was they took 3,200 smokers who were in a treatment program in a cancer setting from 2006 to 2015, did a variety of different counseling and interventions, including in-person consultation, phone counseling, and 10 to 12 weeks of pharmacologic treatment with either nicotine replacement, bupropion or varenicline, et cetera. And basically found there was pretty decent sustained abstinence at about 45% at 3, 6, and 9 months, which is pretty good. And there's an accompanying commentary that makes the great point that basically oncology care clinicians would never countenance withholding chemotherapy, radiotherapy, or surgery for patients with cancer who need it. The failure to deliver smoking treatment to patients with cancer who smoke should receive similar intolerance. We oftentimes don't think of these kind of social and behavioral things as part of comprehensive treatment, and it's important.
No, definitely. I also just wanted to point out that the response rates were pretty good, actually, because it's hard, when you're looking at something over time, it's really hard to retain all the original participants, but I think it started up in the 90%, 100% and then 90%, and then I think it only went down to about 80%, so pretty good.
Yeah.
It's very comprehensive.
And again, not 60 years, but still pretty good.
No, exactly.
Right. All right, what's next?
All right, next we've got the Association of Rotavirus Vaccination with Inpatient and Emergency Department Visits Among Children Seeking Care for Acute Gastroenteritis, 2010 to 2016. So this was a study that was trying to look at the association of Rotatech and Rotarix vaccines with inpatient and ED visits in the U.S. For essentially rotavirus infection. So they were trying to see the vaccine effectiveness or efficacy. And they used a new vaccine surveillance network, which is a combination of 7 U.S. pediatric medical institutions. And they used a negative case control design. So essentially what this is, and this is something that's becoming more popular amongst people that are looking at vaccine effectiveness, basically you take everybody that presents with symptoms that are suspicious for the infection that you're looking at, and you test everybody. And those that test those that test positive, and then those test negative, and then you look to see who was vaccinated. And from that, you can sort of calculate what the estimated vaccine efficacy or effectiveness is. So in this case, they took stool samples, and they did both, they looked at enzyme immune assay, as well as genotyping when they could, as well as PCR, and then they found sort of who tested positive, who tested negative, and who was vaccinated. And so they found that of 10,000 children, 1,100, so 1,193 kids were tested positive, and 9,600 tested negative. And they found that just one dose of both vaccines would provide about an 82% protectivity, and this was in inpatient, and this went down to 75% in the ED. And they also found that patients that weren't vaccinated actually had more severe infections, so up to 4 times more than those that were vaccinated. And they also did some analysis looking at fluctuations with age and clinical severity, but I think all in all demonstrated that the rotavirus vaccine is fairly efficacious.
Yeah, and it's really interesting to me because figuring out vaccine effectiveness at a population level seems really hard. You need to collect a lot of data and say, how did people with the vaccine, how many people got the disease, and how many people didn't get the disease, and that's a ton of work and really research heavy. So this test negative control design is really interesting to me. I think Mike and I talked about this months ago on a flu vaccine paper, and it certainly makes sense. And some of the numbers that stand out to me too, where I think overall of all the 11,000 kids, 87% were vaccinated. Yeah. But of the kids who had rotavirus, only 60% were vaccinated, which makes sense. Yep. That's plausible. And again, those numbers you were talking about, it was even a single dose of vaccine was 90% effective in decreasing your chance of getting a severe infection. Overall, yeah. Which is pretty helpful. In rotavirus, it's one of those vaccines that I think had a little more controversy because gastroenteritis is generally not fatal and is not that dangerous, but there's still a lot of costs, a lot of harm, a lot of worry that parents had being sick in the hospital, et cetera. And the more we can do to get kids healthy and out of the hospital, that's better for most people. Absolutely. Which is nice. Yes. Yeah. All right. So next up, changing to the other end of the age spectrum or the life spectrum. This is a paper that looked at the overall health system and costs associated with intensive end-of-life care medical services. So this stuff's not surprising at all, but they looked at 49,000 patients with cancer who were either in the Medicare or in the VA system. Basically saw in the last month of life, those patients who didn't get any ICU, did not have an ICU admission or no intensive care, cost about $7,700 to the payers. And for patients who did get intensive care, it was about $24,000, which is obviously a lot more. It was about 60% of these patients with cancer who were getting some sort of intensive care at the end of life. Most of that money was just the ICU care in general. That was about $21,000 on average out of the $24,000 or so. Some of it was from the chemo. And not surprisingly, these patients got more intensive services. They were more likely to get chemotherapy. They were more likely to get hospitalization. They had more likely to have 2 or more ED visits, and also were more likely to have few days of hospice care, which is one of the things we know that oftentimes that we are bad at identifying who is at the end of life and getting them to appropriate hospice and palliative care. And a lot of patients get entered into hospice care very, very late. Absolutely.
The other thing that I thought was sort of interesting, it's a minor point, but they looked at the difference in costs between sort of getting one service versus coming back and getting multiple services. And so there was definitely a statistically significant difference between the first and the second. But actually, as you got more services, that difference went away, which is sort of interesting. But regardless, the costs definitely went up. And I think this kind of study is actually pretty hard to do for a number of reasons. And we don't really talk about it enough, but I'm glad that it was done and that we can talk about it now.
And it's obviously no surprise that patients who get more intense care cost more money. Right. That's pretty much a given. And this isn't necessarily a judgment that everybody shouldn't be getting more intense care, and identifying who's in the last month of life prospectively is difficult, as we talked about previously on one of the death prediction papers we had talked about here on the broadcast. But the just being able to quantify the differences is helpful, especially because this is a lot of money, and money we're spending in one place is money we're not spending in another place because there's only so much, and figuring out the best way to do it while respecting people's wishes and all that humanity and all that other stuff's important. All right, moving on. interesting. There's a lot of studies in a lot of different directions on what alcohol consumption means in older patients with mild cognitive impairment or dementia. This paper looked at 3,000 patients who are over 72 to try to look at the different types of drinking patterns and see how that infected them moving to dementia, whether they had mild cognitive impairment or not. Basically found various patterns, but that patients without mild cognitive impairment, daily low quantity drinking was associated with lower dementia risk compared to infrequent higher quantity drinking.
Yeah.
Which is interesting.
Yeah. I was actually just impressed at how often they were doing these assessments
Right.
every 6 months.
Yeah.
That's pretty impressive.
Yeah.
To be able to get this information.
Yeah, and of course it's all observational, so we don't know that drinking causes
Right.
dementia or anything like that. And who knows, but it's more data to help round things out. Last paper we've got, this is an interesting paper looking, readmissions have been really hot for a number of years. We know we're readmitting a lot of people. These authors looked at what happened in patients with cardiac arrest and how much they got readmitted. Because we obviously talk a lot about cardiac arrest, either out of hospital or in a hospital, and how we best take care of these patients, whether to cool them or just control their temperature or what drugs to give them, et cetera. And this paper looked at post-discharge, what happened, and they found that 1 out of 5 were readmitted to the hospital within 30 days, which is not surprising because, if you died, you were probably pretty sick.
Yeah.
And then there were some other associations, some things like the patients who had PEA or asystole as their rhythm were more likely to be readmitted, but not by a huge amount. The most common reasons to be readmitted were for CHF or arrhythmia, which is about half of it, which is not surprising. And the non-cardiac reasons were mostly pneumonia and sepsis, which were about 1 in 5 of that, or COPD exacerbations.
I was surprised at what a large percentage were actually due to non-cardiac causes. And I mean, it's not parsed out here, but I wondered if particularly like the pneumonia type of thing, I wondered if that was something that was acquired from the hospital,
right.
or if it potentially, particularly with the COPD and respiratory failure, if that was coming from the group that had sort of non-cardiac causes of their arrest initially. Yeah. So it's hard to say, but I thought it was sort of interesting.
Yeah, and just speculating here and extrapolating for what we know about other things like an ATLS for we talk about the cause of death and trauma. There's a bunch of people who die immediately because of their aorta is transected or they have a devastating injury. There's a bunch of people who present with life-threatening injuries that are potentially fixable, in those next number of hours. And then it's basically just getting them to not die of complications of intensive care, essentially, not to die of the PE from the DVT from being in the ICU or from the Klebsiella pneumonia they got from being on the vent.
Right.
And so some of it's probably that. I would totally speculating here. And some of it's also just, like the PEA asystole patients were probably less likely to have a primary cardiac event if that's the presenting rhythm.
Right.
And then so, these are older, sicker patients, who, having had a cardiac arrest is generally a pretty big marker of comorbidities.
Definitely. Yeah. Really interesting.
Yeah. Right. So that's all we got today. You can read these papers and more at JAMAnetworkOpen.com. Everything's free and open access. The new releases are coming out tomorrow, Wednesday, and Friday at 10 a.m. Central Time. Join us next week, Tuesday at 3 p.m. again. And, of course, follow us on the usual social media channels, Twitter, Facebook, LinkedIn, and Pinterest, and YouTube. Thanks for joining us.
Thanks, everyone. And also, if you happen to be at ID Week, I'll be there tomorrow through Sunday, so stop by and say hi.
Great. Take care.
Bye.